Good evening. Today we'll start, we have a lecture on osteolysis following a post THR. How do you diagnose and what are the management of this condition, which is very difficult condition. As you are aware, the osteolysis is a silent killer of a joint replacement created by us. And that's last time I told you regarding where the term was coined by Bill Harris, that is William Harris. It's called particle disease. Initially, it was thought to be a cement disease. And that's why everybody started blaming cement. So that's why the most Europeans went on to the uncemented. And after 10 years, 7 years, they realized the osteolysis is also taking place for uncemented hip. So the cement disease coined term was changed to a particle disease now today. So last time this X-ray also I told you this post-op X-ray, and after 17 years, and the massive amount of osteolysis has taken place. Look at the massive osteolysis, the whole cup has gone, and it is impossible to reconstruct this patient. So we can't wait to happen this. So you need to tackle them at the earliest, and unfortunately we don't have many clinical signs, which will come to it. So what about the particle size? Particle size which are less than 0.1 to 0.2 micron are responsible. The larger particle, last time I told, are not taken by the phagocyte and macrophages. So the smaller particle make the havoc. And from where these particles are coming? So there are actually 4 sources, which I described here, 3 sources, but I'll tell you the 4th source also. The first source is articular surface source. That is between the inner part of the poly and the femoral head, whether it can be ceramic, it can be metal, it can be whatever it is. So the articular surface wear corresponds to almost 70 to 95%. Now second wear of uncemented, which started initially we didn't had in cemented hip, uncemented hip. In a cemented hip only we had an articular surface. And uncemented implant came when the locking mechanism was problem. We are not able to lock them well. They start what is called backside wear. The particles, fortunately, they are not very small, they are large particles. Then the third is the third body particles. There are some particles which comes inside the joint from the synovial tissue, from anywhere. Either they are metal, cement, or whatever they are, particles, bony particles also. And they produce third body wear. And the fourth one is what we call as an impingement. When there is a neck impinges against the poly or any metal part or on a ceramic, which we showed you last time, the impingement there also is one of the source of the particle degeneration. And double mobility produces the large amount of impingement, because the moment of double mobility starts after hitting that implant, after hitting the poly. Okay, we will discuss sometime when the double mobility comes in action. So we have 4 sources of articulation of wear. So articular surface, backside wear, and third body, and fourth is from the impingement. And which particle are responsible, we still don't know. We are not able to separate them, unfortunately. So that is the reason we really are worried. So what about this debris which occurs? And this is the histological section, and this is the polyparticle into the giant cell. This is giant cell, and this is a polyparticle, and these are all lymphocytes and infiltration. So whatever the debris comes, the nature is great. The macrophages take the phagocytic and from lymphatic system, the normal whatever the load is, it is thrown out from the lymphatic system. But if the particle threshold goes up, generating large generation of particles, then abnormal load stimulates the periprosthetic granuloma. So every patient does not get, those who got a low wear, low demand, which I am going to show you, will not produce the periprosthetic granuloma. But younger patients, high rate, genetic institution can produce abnormal load and leading to this. So The particles are taken by the macrophages. They produce cytokinin, and these cytokinin destroy the osteoclast, that is called pre-osteoclastic and then clastic osteoclast resorption takes place. We will go into the more detail of this. This is a very lengthy slide, but unfortunately this slide for a PG, I think it is required, and that's the reason I have to put this. I never put this such a long slide. So you need to understand the phenomena of this osteolysis. Possible model of interplay between, this is a very important statement, macrophage, fibroblast, lymphocyte, osteoclast, and osteoblast in periprosthetic osteolysis. They have an interrelation between all of them. One is not responsible. Everybody is almost responsible. Some of them are prominent. So osteoclast develop from the precursors under the influence of rankle. And rankle is nothing but receptor activator of nuclear factor kappa B ligand. That is known as rankle. The source of rankle can be a macrophage, can be T lymphocyte, T cells. So any of them can be a source for rankle, and the rankle is the ultimate responsible for getting damaging the osteoclastic activity and stopping the osteoblastic activity. The source of rankle can be this, and particles, they stimulate one of them. The particle may stimulate macrophage, fibroblast, osteoblast directly to induce rankle and pro-inflammatory cytokinin. This is important. They also release pro-inflammatory cytokinin that also can induce rankle, and it has been hypothesized that T cells stimulates by pro-inflammatory microenvironment because of that environment of particles may also promote the osteoclastic formation, synergize with alpha tumor necrosis factor by secreting interleukin 17 and a couple of them, plus the rankle, TNF alpha, interleukin 1, 6, 17, and MCSF. These are 5 responsible factors for damaging. These are the cytokines. They are going to damage the bone. May mediate through a differentiation of myeloid precursors into multinucleate osteoclasts like giant cells and development of impaired osteogenesis. So what people have done, the periprosthetic membrane at the time of revision, they had taken out this membrane and they have done into the animal model, they injected this and retrieved revision surgery, produce variety of factors including TNF alpha and all these factors involved in mediating osteoclast biology. Thus, the factor induce the final effect of molecule is rankle, and it is generally accepted now today. So rankle is one of the responsible. It is stimulated by osteoclast, fibroblast, or macrophages, and the stimulation and this after the stimulation of cytokinin and tumor necrosis factors are there, which are responsible. They also stimulate rankle. So this is the circle goes on with osteolysis. And this figure is extremely important. If you can draw the figure in exam, probably the examiner knows that everything you have understood regarding the osteolysis. Now, going through one by one, these are the particles are taken by the macrophages, and these are dicotomide adenosine dinucleotide phosphate hydrogen, which also stimulates the nuclear factor kappa light chain activated the B cells, and these B cells will produce cytokinin, and these are actually cell morphological, these are live cells actually, these are the live material, and this will stimulate the cytokinins, and these are the cytokinins which are responsible. So TNF alpha, interleukin 1, interleukin 6, and they also, I told you, stimulate fibroblast. They also stimulate fibroblast, not that, they also stimulate both osteoclast and osteoblast, but osteoclasts are less compared to osteoblasts are much more less compared to osteoclast. So all these factors will stimulate osteoclast, and the rankle itself will produce again stimulate interleukin 17, and these are again these T cells are again stimulated by TNF alpha, interleukin 1, and interleukin 6, And this rankle, the precursor shape of osteoclast, not the osteoclast, precursor shape of osteoclast go and hits the osteoclast through rankle, and they start damaging the whole of the bone material, and increase resorption and impaired osteogenesis. And rankle also has one of the important factor. It inhibits osteoblastic. Not that it does both. It the bone and also inhibits the osteoblastic activity. That's why it's responsible for both the things. Both the things. Is it clear, all of you?
Yes, sir.
Go ahead.
Yes,
this is
sir.
a very important pathophysiology. If they can put this figure into the action, probably they will know the osteolysis. I'll go ahead. Okay. So osteolysis, cemented socket is different, uncemented socket is different. Cemented socket, we don't see much osteolysis because the fibrous tissue comes at the level of the bone cement interface, and it acts as a barrier for destruction of the bone. The fibrous tissue does not allow the particle to penetrate. So we did not see much osteolysis in cemented hip. It is a very, very important factor. In uncemented socket, joint fluid passes in the least area, and there are no spot welding. Through that, in between the area, the particles will run through. Sometimes they run through the channel of the screws, and that's why we were not able to. We are avoiding the screws many times. But today, it is not because of the highly cross poly. We are not worried about putting a screw or not to put the screws. So today, data is slightly different. Anyhow, to understand you, a cemented socket osteolysis is different because it does not allow there is a fibrous tissue at the interface and it's a barrier. But here, there is a least area of resistance where there is not spot welding has not taken place. There is no fibrous tissue. So directly the particles are pushed inside into the socket area. So wear rate, I had last time also told you, wear rate in cemented orthoplasty is 0.007, uncemented is 0.15 per year. And there's enough data available with us. But new cross-link poly, that has reduced. But very important, and all of you must remember, this new poly is not immune for osteolysis. We will see it maybe after a couple of years. Up to 13 or 15 years, we are not seen. Probably next decade, we will like to see this because these particles are submicron and they are very high. The osteolytic response is higher. It is actually aggressive because particle size is smaller. So what are our clinical signs are? Absolutely poor clinical signs because patients usually do not complain. They have minor discomfort, they ignore, and they come to orthoplastic surgeon, and we take an X-ray. X-ray is fine, you go, nothing required. He comes after 7 years, he comes after 9 years. No, X-ray is all right, so nothing to worry. Just they go ahead, and you miss them because clinical exam, there's nothing. What you have to suspect after 7 or 10 years is they will have very mild discomfort. They will say, sir, up to 7 years I was all right, but I got something which I can't explain. So you need to do something which I will tell you what you have to do. And they're often asymptomatic. Some of the patients have come regularly follow. For 90% patients do not come for follow-up in this country. And what happens to them, let's see. Suddenly, they will call you, sir, I just can't walk. So there is disaster, catastrophe has taken place. Either implant has suddenly got a loose or he has developed periprosthetic fracture. Especially trochanter fracture is very, very common. And that's why yesterday only I received one of the phone call and I got an X-ray, I got something else to done and I picked up the trochanter fracture. So on plain X-ray, you may not pick up the trochanteric fracture because osteolysis is massive in this trochanteric area because of the dependent area. So normal AP and lateral X-ray are not reliable. Best sometimes if you have to, we don't have any access to CT, best is to get a 45 iliac view and 60 degrees obturator oblique view. And lytic lesions, only we are able to see when 20 to 30% of bone is lost. In that time, we can't see on the X-ray. So X-rays are not reliable for osteolysis. So there is a threshold for the x-rays and other thing are. Threshold is modified by, there's a capsule, and there is a pressure. So if the pressure is high in the capsule area, the particles will push inside or push into the trochanteric area, push on the lesser trochanter area. Second, bone interface access. If it is sealed by spot welding or a cemented hip, the particles are not going to push inside. Third, patient reaction to debris. Some patients behave differently. Some patients behave differently. So I'm going to show you 2 or 3 fantastic examples from our own series that the massive wear has taken place, but there is no osteolysis. Don't know why. And it is my personal observation that ankylosing spondylitis, very high rate of osteolysis. I am unable to prove because I need to do a randomized study, which is not possible in our country. So this is my personal feeling. The osteolysis is much more in ankylosing spondylitis. So this is the patient. Look at this, 1985, cemented, look beautifully done. This is the poly. And after 13 years, look at this massive 6 or 7 millimeter wear has taken place. And this patient does not have any osteolysis proximally or around the developed on the ischium. Normally, you get a lot of osteolysis in the ischium. And look at this cup which we have removed. Look at the obliquity of this obliquity of the cup. See the wear, it becomes oblique. So this patient did not develop osteolysis. We don't know why. Actually, 6 millimeter to wear, it have got a massive osteolysis. Second patient was a doctor physician. 1980 was operated, and 22 years later, look at this. This was the hitting the almost a metal ring inside. That is a wire marker inside. And look at this. And he had a massive wear, and this is also a recurrent dislocation which is happening here. And this is the fourth part of the wear, which I told you, impingement wear, which also this is the fourth part of the wear, which I revised this patient. And look at that, no osteolysis after 22 years. So we really don't know. So genetics also plays a role in osteolysis, and there's a lot of work going on. So what is the gold standard to pick up the now osteolysis? X-rays are not reliable. 30-40% till that were not reliable. So we today, CT is gold standard, not MRI for osteolysis. CT scan is gold standard, which I'm going to show 1 or 2 CTs. It gives a location, it gives a size, there is a classification on the size, it shows a pelvic discontinuity, and this is the method of CT. The Puri et al. 2002 JBJS has classified on the CT scan. It helps in revision protocol, which I'll also show you, because we need to do a trapdoor entry for the bone grafting. So on the CT scan, we have to know the lesion is anterior, posterior, medial, where it is. And this is a great work by Stulberg. First time he reported silent osteolytis. All patients who are operated after 10 years or so, he did a CT scan of all the patients, and he saw there are no symptoms. And the silent osteolysis was 49%. So it is my now dictum in our unit. After the 10 years of follow-up or 7 to 10 years follow-up, if the patient comes for follow-up and complains something minor, the role of CT scan is must. And that picks up. And one example, I'm going to show you a very young lady, which we have picked up. So this is one patient, beautifully done, everything is fine. This is almost a 10 to 15 years follow-up. And look at the CT scan. Big lesion, and there is a pelvic discontinuity. On X-ray, you cannot see any pelvic discontinuity. So CT can give this size, location, and pelvic discontinuity. Very important finding on CT scan. So what is our treatment goal of these patients are? We need to arrest the lesion, remove the poly generator mechanism, whether it can be a highly cross poly or simple poly, it can be ceramic, it can be metal, whatever it is. So we need to put the new poly. You've got to put some graft if the lesions are big. Put a graft so that it can heal. Prevent impending periprosthetic fracture. You must operate them earlier, especially on the femur side, before they fracture. Once they fracture, the surgery becomes complex. If the stem or acetabulum or both are loose, revise them, because you have to aim to restore the bone stock. And further medical management, we will come as a last, what medical management we can do for this patient after liner exchange or after whatever the treatment is. So there are new drugs which you can use it. We have just started using maybe 2 or 3 years. We don't have a large experience, but that is one the people are doing. So as far as exam is concerned, you need to put that into your answer. So on a femoral, now we'll start on the femoral, then we'll go to acetabulum. Femoral osteolysis class, there are numerous classification. There is a double AOS classification, MGH classification, William Nolan's classification, but I'm going to come to some practical solution which is easy for you to understand. Now, type 1, it is a well-flexed implant. There is a metaphyseal lesion. The track record of the implant is good, whether it is extensive or proximally coated or HA coated, whatever. The track record of that implant is good. If the track record of the implant is not good, you will have to take it out. So what the treatment or for these patients are: stable femur, treatment, put a new poly, that you take out the generating poly, the machine, generating machine, debride and graft the metaphyseal lesion. You put a new poly and graft and either debride the area, the proximal calcar and the trochanteric area, and put a graft and metaphyseal lesion. Sometimes during this procedure, there is a possibility of trochanter fracture, very common, because there is osteolysis. I told you a lot of trochanteric area. So you have to get a prophylactic wiring done for this patient sometimes. So this is one example. This is a very minimal metaphyseal lesion, and the whole thing is loose. So it is, we have to put a new poly, new cup and new poly both, and the metaphyseal lesion will heal. This is the second example. Look at the metaphyseal lesion. And already trochanter, there is a fracture. On the CT scan, if you look here, there is a trochanteric fracture, there is no medial bone. So there is no medial bone. What we did for this patient is, we put a trochanteric wiring, and medially we put a stud grafts from the tibia stud graft, allogeneic graft. And this is almost about 6 or 7 years of the follow-up of this patient. So this is and we put a new crosslink poly, and everything is beautiful. And she's walking around almost for, it's a 5 years follow-up of this lady. So we have to reconstruct the proximal bone. And what is the data today? There are two good data coming out, Maloney and Benson, that whatever the new poly has taken place, proximal grafting has done, no further femoral loosening has taken place. That means the poly particles are not going inside. Again, both these papers suggest that there is no femoral next revision at 5 years, at 7 years follow. So it is a good procedure. So that is type 1. Again, repeat, small metaphyseal eccentric wear of the poly, and that's why it is possible. We put a new poly and graft the metaphyseal lesion. Now second is well fixed implant. Metaphyseal lesion, now it is going slightly on the diaphyseal side. Now we need to probably revise the stem and put a new poly both together. So this is one important thing. Metaphyseal is accessible for bone grafting. Diaphyseal lesions are not accessible for bone grafting. This is very important because you can't reach. So this is such patient. Track record of this implant was not good because this patient was operated many years back. So this was operated at AIMS. So I was not knowing what is this implant, 25, 30. So I asked the AIMS people, can you give me a record? And luckily, I got a record from the AIMS because AIMS has got a fantastic registry library there. So they had told us this implant has been taken out from the market and there's no way we can do it. So I have to take out this implant, proximally coated implant, osteointegrated, some amount of lesion here, lesion there. And a CT scan definitely shows some area diaphyseal lesions also. So I went and took it out. And revised this. And this is I did some amount of grafting on the medial side, from the acetabular side. If you look back, there's a lot of protrusio there. There's a lot of protrusio which has taken place. I grafted that. And this is about 2 years follow-up of this patient. Now it is almost 8 or 9 years. 9 years for this patient, but I don't have the long-term follow-up of this patient. So how this is beautifully lesion has healed. So everything is fine. So this is the track record is not good. You got to take it out. Second, if the lesion has extended into diaphysis, now you look at this, the lesion has gone into diaphysis. It is not only in the trochanteric area. Now it is extended almost 6-7 centimeter. And I don't know what this was. I inquired regarding this patient. What was this surgery? Why? And the surgeon was not able to take it out. A lot of people have tried. This was a very, very difficult operation for me. How to take out this. So I made a window here. And I used the carbide drill and made a punch and then hammered from here upward. And I took it from what you will call as a anticrate. Okay, that's the way that I took it out, and whole trochanter was shattered. So I had used, I told you, most of the time this osteolysis trochanter gets shattered and there's a chances of fracture. So I just put a couple of wires here and look this, how it is beautifully healed at 2 years from. Look at the lesions have started healing, and this also window has almost healed. So that's the way we worked out with metaphyseal diaphyseal lesion. We need to revise. Third, very straightforward. Loose implant with severe osteolysis, you have to take out everything and do it. So these are actually massive surgeries because there is nothing like diaphysis, nothing like metaphysis in these patients. Now this is an example. This was again operated way back by myself, maybe about 35 years back. And this has a Mullah Ring here, but it worked for so many years, not bad. And then you look at this osteolysis, so much osteolysis around. And this is a lateral X-ray. This all is osteolysis here. Look at this. This is all paper bone. I was unable to hold with any bone holding instrument. It was just cracking. Everywhere it was cracking. And this had already made a window here. So it was a very, very ghastly osteolysis. The bone quality was extremely poor. So what I did was a calcar replacement prosthesis, grafted this area, and look at a couple of, maybe about 6 months or 1 year, completely reconstituted bone completely. You have seen pre-op and you see the post-op. So this is what the healing takes place because it reads a good distal fixation. So proximal bone recovers well. And this is again one of the severe osteolysis, complete proximal whole segment has almost gone. So, and look at the wear which has taken place. So much of massive wear has taken place. And this patient also here, look at the after completely distal fixation, whole proximal bone recovers. And we have to make a small window here. If you look at this, this is called varus remodeling. One important message for all of you. Whenever there's a varus remodeling, it does not allow the entry to take place. Once you start enter, it will go out. Your reamer will go out. This requires, if it is 10 to 15 degrees, requires window. If it is much more, you require corrective osteotomy. Many surgeons have done a lot of complication with this varus remodeling. It is not a good proposition. So I have to make a window here, and I use a prophylactic wire, not that to splinter, avoid splintering. Never seen such a massive osteolysis. Can you see this? The whole acetabulum, whole femur, there's a massive osteolysis with this titanium grid blasted stem or something. I had not revised, but I had seen this patient, but I had not revised this patient. But just to show you, this massive osteolysis can take place. So for this, you revise everything, or this patient will require proximal segment because there is no bone here. So it will require proximal segment, either LPS system. On the trochanter side, and when the trochanteric osteolysis takes place, I told you, you require sometimes fixation, which I showed you one case. Second case I'm going to show you. This is the girl, young girl. I had operated this girl way back, 28 or 30 years back. And after 15 years, she came for a trochanteric osteolysis. And this cup, probably you will not know it, this is a monoblock cup. Even though there was some wear, it was a monoblock cup. There is a monoblock cup, it's very difficult to take it out, and plus you can't put a liner inside. So I left at that time, and we didn't have that amount of knowledge what today we had. So that time I made a special hook plate. That time it was not available. So I made a hook plate and put a trochanteric plate. I did a tension band also along with that and grafted from the iliac crest of her own bone, autogenous. And 3-4 years back, she landed in Shelby with osteolysis, and I revised the both cup as well as the stem. You look at this, there was a lot of cement here, so I made a small window here. I left the plate there. I just loosen out the screws, these 3 screws here, 2 screws here, and I got entry, and after that I tightened them. So this is the follow-up of this lady, maybe 2 or 3 years follow-up. So this is the way the trochanteric fixation, either you put a trochanteric wiring or put a hook plate. That's the reason I wanted to show you. So for now we go to estabular. We finished on the femur side. Type 1, type 2, type 3. Type 1, where eccentric wear, metaphyseal lesion, graft or trochanteric wiring. Is type 2, when there is extending lower down, your diaphyseal lesion does not access for bone grafting. You might have to revise. And third is completely loose. You will have to reconstruct and get a distal fixation done. That's the way 1, 2, 3. Now we will go on a pelvic osteolysis. On acetabular side, acetabular, clear guideline for revision. Today, we do not have clear guideline for uncemented, still today. So we are now using a presumption and assumption. What is the cemented guideline? Any patient who has a radiolucent line in all 3 zones, Charnley 3 zones in AP and lateral, revise, even though patients are asymptomatic. That is the guideline today. Second guideline, eccentric wear more than 75%, revise, don't wait. That is the way we worked on cemented. Uncemented guidelines are not clear, but we are now getting agreed, all orthoplastic surgeons. Progressive osteolysis, follow every 3 to 6 months on CT scan, not on x-rays. Complete head penetration, patients are asymptomatic, you do revision. I'm going to show you examples. Clear? So,
Yes.
Hello, sir.